This is part 2 of the lecture on image-detected extranodal extension in head and neck cancers. You really want to see part 1 before watching this half. Let's move on now to grade 2, which is coalescent or matted nodes. Here you can see two level 1B nodes that no longer have a margin between them. They have come together into a single mass lesion. They have lost the border separating them along their outer angle. You can see that they're adjacent to the submandibular gland, but there's no direct invasion of that gland to definitively declare that this is grade 3 iENE. These two nodes together are enough to be grade 2. We used to say that you needed 3 nodes in a cluster to be matted nodes, but now we recognize that 2 is sufficient. 2 nodes is sufficient to consider them coalescent. But how do we know that those two nodes right next to each other are truly invaded into each other? There are 3 criteria that we're going to apply to reassure ourselves that we're truly seeing coalescence between these nodes. The loss of a fat plane between the nodes, the loss of convexity at the point of contact, that is, they need to flatten against each other like jelly beans instead of like spheres, and the loss of an acute angle between the nodes. They can't just be kissing each other. They have to have a broad base against each other, like meningioma against bone. Let's see all 3 of these in an example. Sometimes there's just a ton of nodes all clustered together, and there is no doubt that these are all confluent with one another, coalescent into one another. There's just, 50, 60 nodes here, and it's obvious. Sometimes we need to return to this example and talk about those 3 criteria: loss of fat plane, loss of convexity, and loss of acute angle. So is the fat plane gone between these 2 nodes? Yeah, there's no visible fat between them. Okay, that's easy. What about loss of convexity? Is there still a convex rounded surface where the 2 meet? No, it's a straight line. It's a flat surface. What would have been a sphere here has become flattened on both sides. So loss of convexity along that surface. And then the third thing is that one of the angles between the nodes needs to have the loss of its acute angle. Now there's still an acute angle here on this side, but here it's almost flat, almost 180 degrees. That acute angle is lost on the outer surface. So all 3 of the criteria are met, and we can be confident that this is in fact coalescent adenopathy and grade 2 disease. Now, sometimes this loss of an acute angle may not be evident on a single reformat, and you may need to go to coronal and sagittal images to find that. But if you can find it on any of the sequences, that is sufficient. Here's another example. Let's go through those same criteria. Is there a loss of fat plane between these 2 nodes? Yes, there's a loss of fat plane. I don't see any fat in there. Is there a loss of convexity? Yeah, we're flattened right here, right? This is no longer a circle. It's flattened there. It looks more like a dumpling. Here it is on the other side. There is the flat surface, right? So we have loss of convexity. Do we have the loss of an acute angle? Yes, there may be an acute angle on this side, but on this side, that acute angle is lost and flattened. So that is grade 2 adenopathy. You may think, is this even grade 3? Have we gone out all the way to the skin? Well, I don't see skin thickening here. You may claim that there's some invasion there, so maybe possible or probable, but there's definitive grade 2. Here are 2 nodes on ultrasound, 1, 2. Once again, you can see that there's no fat between them, that they've both lost convexity at that interface, and that there is no longer an acute angle where they are touching one another. So all 3 criteria met on this ultrasound. This is not grade 2. These 2 nodes are in contact with one another. We have lost the fat plane between them, but they still have rounded surfaces. They are not flattened against one another. And there is still an acute angle where the nodes meet one another. So these do not qualify as imaging extranodal extension. Here's an example on MRI where you can see these three nodes stacked on top of each other. Have they lost the fat plane between? Absolutely. Have they lost their convexity? Yes. There's a straight line there. It's no longer convex where the nodes meet. What about the angles? There's still preserved acute angles between these nodes, so this is not coalescent lymphadenopathy. Now, to be sure of this, I'm going to have to look in other planes. I'm only showing you one image here. Maybe in sagittal or axial planes, it would be more evident that these are coalescent, but at least based on this one image, you do not have evidence of grade 2 iENE. So once again, those three criteria: loss of fat planes between the nodes, loss of convexity at the points of contact, and loss of an acute angle along the margins between the nodes. Be careful in calling grade 2. There are several mimics. A lobulated margin on a single node can look like two nodes growing into each other. If you have solid and necrotic regions within a single node, it may look like two different nodes, one of which is solid and one of which is necrotic, but that's not good enough. And once again, beating a dead horse here, but use multiple imaging planes to reassure yourself of the presence or absence of coalescent adenopathy. Here's an example that should not be called grade 2. This is one mass with a medial lobulation. Now, is it possible that these are two nodes that grew together? Absolutely, it's possible, but it's not definitive because we frequently see lobulation of a single node. So this is possibly iENE, but it's not definitive, so it can't be used for staging. You have to be sure. We're moving on now to grade 3, which is invasion of surrounding organs. We're going to start with an obvious case. I mean, this lymph node is just destroying everything in the vicinity. I can't even find the sternocleidomastoid muscle. We've extended out to the skin surface here. There's probably involvement of the arteries as well. A blatant example of extranodal extension into surrounding organs like muscle and arteries and skin. So definitive grade 3 iENE. So here's a situation where you might be wondering, oh, I'm not sure if this lymph node is invading that internal carotid artery there. It's only touching it on a small surface, and we'll come back to that. But it doesn't matter because there's such obvious invasion of the paraspinal musculature here with definite fingers of tissue extending into that musculature and extensive destruction of the sternocleidomastoid muscle. There's only a little bit of it remaining. Most of it's been eaten away by the tumor. So here's definitive muscular grade 3 iENE, regardless of how certain you are of the artery. So a couple of points about grade 3 iENE: the loss of fat plane between the organ and the node is insufficient. Displacement of a gland or a muscle is not sufficient. If you see a little bit of enhancement within the organ that is being invaded potentially, then that's not enough. You need to see the tumor extending in, finger-like projections destroying the parenchyma of that organ. In the arteries in particular, we want to see encasement. How much encasement? Well, 270 degrees that we often used to declare definitive encasement of an artery still works here. So 270 degrees around the artery is considered encasement. If you see tumor thrombus inside an artery or a vein, that is sufficient to indicate that it has been invaded. We're only talking here about major arteries: the common carotid, internal carotid, external carotid, vert. If you see a branch of the facial artery that's invaded, that's not sufficient. We're really only talking about major arteries for arterial involvement. With regard to the jugular vein, compression and displacement of the vein is not sufficient. You have to see tumor thrombus, or the vein has to be completely obliterated, no flow at all because of the node. Now, in order to make that distinction, you almost always need to have intravenous contrast to see that. Direct nerve invasion, usually you can't see. You rely a little bit on perineural spread, but we're looking for direct nerve invasion. you can use the downstream effects. If you see muscle denervation in the distribution of a nerve that you're considering, that's sufficient sign that the nerve is indeed invaded. Be a little careful when a primary tumor extends out and into the surrounding soft tissues and merges in with a node. We see this in the hypopharynx with level 3 nodes. We see this in the nasopharynx, the retropharyngeal nodes. If you see that merging of node and primary, that counts as grade 3. That means that the node has eroded all the way to the primary, except as we talked about earlier, retropharyngeal nodes and nasopharyngeal carcinoma so frequently have that appearance of a single unit that we're not going to count that. So except for those retropharyngeal nodes and nasopharyngeal carcinoma, the merger of node and primary is considered grade 3. So here's an example. At first, this looks pretty well defined. This node has very well-defined margins, but where's the jugular vein? Actually, those arrowheads indicate that what's left of the jugular vein. This is tumor thrombus extending into actually an expanded internal jugular vein. That's grade 3. Tumor thrombus within the vein is grade 3. Here's a very similar appearance, this time on ultrasound. This is the node. This is the internal jugular vein, and you can see direct invasion into the vein, forming tumor thrombus. Grade 3. This is not grade 3. Here, the internal jugular vein is compressed, but it's not definitively invaded. Right? You can see it stretched out over the edge of the tumor, but I don't see any tumor thrombus in the center of it, and obviously it's not completely obliterated. It turns out that in this case, this actually is a grade 2. It's not obvious on this one axial image that this isn't a lobulation, but it turns out on multiplanar evaluation, this turns out to be grade 2. You just can't tell on this one image. So here's an example of not grade 3. Yes, we have the loss of the fat plane between the node and the sternocleidomastoid muscle, but we don't have definitive tumor within the organ, within the muscle itself. I mean, I would call this probable grade 1, maybe not, but probable isn't good enough, so it doesn't matter. We're not going to upstage this patient on the basis of this CT finding. This has to be considered no evidence of iENE. So in this case, there is definitive extranodal extension, sure. But what grade is it? Is it just invading the surrounding fat, or is it into the muscle? Well, you can see some strands, but those strands don't definitively enter the capsule of the muscle. They don't definitively go through those layers of the deep cervical fascia that surround the muscle. Sure, these are finger-like projections, spiking projections extending out from the node. It's definitive grade 1 iENE, but this is not sufficient to call grade 3 iENE. Just as a reminder, if you see different grades, it's the maximum grade that counts. So if you see something like this where, oh my gosh, I see spikes going into the fat, and oh, I think these are multiple nodes and they're all coalescent, oh, and it goes all the way out to the skin surface and invades the muscle, all of those are true. All grades are present, but only the grade 3, the maximum grade, is relevant for staging. This is a lot to learn about. If you'd like more information, more to practice with, go to the Guide to iENE and Head and Neck Cancer, which is on the ASNR website. Here is the URL, but frankly, if you can remember to Google iENE and ASHNR or even iENE and radiology, you'll find your way right to this. It'll be the first hit. There are many more examples than the ones that I've shown here, some of the ones I showed, but many more examples available on the website to help guide you in better understanding this hugely important concept. All of this was developed by an international joint task force on iENE that is composed of members from the American Society of Head and Neck Radiology, the European Society of Head and Neck Radiology, and the Asio-Oceanic Society for Neuroradiology and Head and Neck Radiology. all working together to produce this. Even if you don't trust me on some of these, you can certainly trust the distinguished committee members who created this guide. I can't emphasize enough how important it is to understand iENE as we start staging our patients with AJCC and UICC version 9.